Okay, so today we will talk about part three exam, how to prepare for part three exam, what be included in part three exam in MRCOG. Normally, I'm usually say that part three exam is much more easier than part two, but it need from you regular practice and repeating of the scenarios and the tasks again and again. So how to prepare yourself for part three exam to make your life easy? So the first thing, most of you are having already passed, or all of you should have passed the part two exam. So you should keep your knowledge refresh. So try to read the guideline, um, including the green top guideline or the nice guideline or even the TOG that you studied. Keep reading this guideline to keep the knowledge in your mind. I'm not saying read it in details like part two exam, but no, just about 20 minutes or 15 minutes for the guideline you wanted to revise, and this to refresh your knowledge again. Okay, because part three, yes, it is a communication with the patient, but still applying knowledge is very important, and some of your colleague may fail due to defect in the applied knowledge. So how keep my applied knowledge up to date or refresh, and this by repeating the guideline which you already read it before. Okay, so don't waste it. The second important source is the patient information leaflet. Very, very important. And this will raise your communication skills with the patient. All right. So the patient information leaflet will uh, uh, learn you how to talk to the patient in a lay language. For example, instead of talking to her, explaining the uterus, you will say womb. And instead of saying the ovum, you will say egg. And instead of saying we will do hysterectomy, you will say we will remove your womb, like that. Okay, so we in part three exam, all of us should avoid using jargon because it will decrease your marks in the communication with the patient. So how I can improve my lay language? I can improve my lay language by the patient information leaflet, and the RSOG already made a leaflet for each guideline. Okay, so when you revise a task or do a scenario, go and read the patient information leaflet of this task, for example, of the miscarriage, of the ectopic, and this will increase your skills in the lay language. Then try to find a study partner from the beginning, and this will also help you during your journey. Um, a study partner is very important because he will able to give you a feedback on your performance when you did some task or some scenario. He will say for you that you lost that, you didn't say that, you did this, say you said this in a lay language, you said that a wrong way. So study partner is very important. Okay, uh, you may find one or two study partner because if you there will be one busy, you may study with the other one. I know that finding study partner may be difficult in some cases because of the nature of our work, and most of us work in different areas, so not the same time. So finding study partner may be difficult in some cases. Is this the case? Try to record your practice. For example, if you are doing practice of ectopic pregnancy, try to record it in your mobile, or then hear it. Okay, then hear it again and again. Okay, you will find what is the missing point in your performance. So in this time you forget to mention that, the next time you forget to mention that, like that. Okay, so as I said, a study partner is very important. Be simple and serious from the start. Okay, I usually say passing from the first time is the best because it will save your money, your time, your effort. Most of us has a work, right, and they will take a study leave um, to go for this exam and to prepare for this exam. So it will be difficult to repeat it again and again, and also wasting the money and wasting the effort. So usually the high chance will be from the first time. If you are serious from the first time that you want to pass this exam, you will pass. Okay, and as I said, it is doable exam, not difficult at all. You pass the most difficult exam in the world, which is part two. So part three should be very easy for you, right? At the end, if you can do one circuit, and this to help yourself to be familiarized what will happen in the exam. If you can do one circuit with in any center or with any mentor, it could be very helpful. Okay, so part three exam. Part three exam is a 14 task. In each task, it will in each task 12 minutes. 14 task for 14 module. Okay, it is the same module that you studied already in the part two, but it in clinical scenarios. So, for example, you will find the task of teaching. All right, so you will find a simulated colleague, which act as an actor. All right, and you will deal with this actor. Core surgical skills, post-operative, early pregnancy, antenatal, maternal medicine, labor and delivery and postpartum, gynecological, subfertility, urogyne, all the module that you studied, you will find the clinical scenario for this module. Okay, so 14 module in the exam or 14 task in the exam, and in each task there will be 12 minutes. We will talk about this 12 minutes in a couple of minutes. Okay, so what you will be assisted there in the part three, you will be assisted for five domains. Five domains, okay? The first one and the most important is the patient safety. You will also assisted with the communication with the patient and the relative, communication with the colleague, information gathering, and applied knowledge. We'll talk in detail about each one of this domain. In the exam, it is difficult to be in each task. It is difficult to be assisted for the five. So you may be assisted for three or four. So, for example, in one task, you may find yourself assisted in the patient safety, communication with the patient, communication with colleague, and information gathering, for example. In one task, you may be assisted for three, like communication with the patient, information gathering, and applied knowledge. So it is very difficult to be assisted for the five domains. Usually we will be assisted for three or four domains, right? So sometimes the communication with the patient can be assisted as a patient safety. For example, if you said, I will inform my consultant about this one. So sometimes even mentioning the communication with the patient can be considered as a patient safety, okay? Please mute yourself till we finish this introduction. There are two types of the tasks in the exam. As I mentioned, this is simulated patient task and the extraction discussion task. In the simulated patient task or simulated colleague task in case of teaching, so you will find an actor there and will already have the script scenario or have the script already with her like you, and already she prompted what to do inside the task. So you will go in the task and you will find two or more people waiting for you. Two or more people mean that it is a simulated patient task. So there will be one actor and one examiner. All right. So don't look to the examiner at all. Don't look to the examiner at all. Concentrate with the role player. Okay, the role player only. Don't look to any other examiner. So the role player already, as I mentioned, she had a script with her about the scenario. She will ask you some question. Sometimes she may show some emotions like to be angry, to be anxious, to be stressed. She is not doing that for you only. She is prompted to do that for all of the colleagues. So Don't say for yourself why she is doing that with me. This patient angry with me. I did wrong. I did something wrong. No, she is prompted to do that. This role player, she is an actor. She is an actor, and she prompted to do that with you. Sometimes she may cry, she may be angry with you. All right, so this not because of you at all. She is prompted to do that. So this is the simulated patient task or simulated colleague in case of the task of teaching. So you will go inside and you will find an actor act as a junior doctor who wanted to learn something today, right? So for example, like breech delivery, like forceps, like ventouse. Okay, so you will deal with him as your junior in the normal duty. Okay, so this is the simulated patient task or simulated colleague task. In the structured discussion task, you will go inside and find one person only, which is the examiner, which is the examiner only. Okay, so one person means that there is this is structured discussion task, and it will be written outside. This is a simulated Bayesian task. This is a structured discussion task, right? So it will be clear outside all for you. But if you didn't read that, all right, if you find only one person inside the cubicle inside the room, so this is a structured discussion task. The examiner will ask you a series of questions about one scenario. All right. So the examiner may be in some simulated patient task in three to four tasks of the simulated patient task, you may find two examiners. So you will find the role player and you find also two people extra or another two people, which will be one is clinical examiner and one is the lay examiner. The clinical examiner, which will assist you today, and the lay examiner, it is one come from the general public, and this to assist your communication with the patient, right? So he didn't know anything about the task. He didn't know anything about the clinical information of the task, about the guideline, about the management. No, at all. He is only come to assist your communication. So usually, this lay examiner will be already there in case of drama. If there is a drama in the scenario, like the patient, you break bad news to the patient, you wanted to negotiate with the patient about the option. The patient want something today, and there will be a debate about the management of the option. So this lay examiner will come today to assist your communication with the patient. How you will communicate with this patient. When the patient cry, what did you say? What did you do? Did you show any sympathy for this patient at all, or you ignoring her emotions and you keep talking? When this patient wanted to do something, did you respect her autonomy? Did you respect her wishes, or you just be judgmental and offering your choice to the patient? Okay, and you didn't respect to her wishes at all. So this is the rule of the lay examiner. Okay, so come to the domains. The domains, as I mentioned, it is a five domains, all right, starting from the patient safety. Patient safety is the most important domain in the part three exam, and no one will pass if he didn't respect the patient safety. Okay, so patient safety is the most important. JMC usually stress on the patient safety, okay, for assessing any doctor here in UK. How the patient safety will be showed in the exam, or how will be assisted in the exam. So, for example, if the scenario need a involvement of the senior, okay, like your consultant in the duty, so this is could be considered as a patient safety. No one work alone in the hospital or in the clinic. So if you mention that I need to discuss this with my doctor, I need to discuss this with my senior, okay, this will be considered as a patient safety. So no one work alone at all. And some of you are already consultant in their job now, and they didn't escalate the things to the others because already they are consultant. All right, so who will escalate for? But in part three, you still SCT5. When you go to the part three exam, you still SCT5. So you need to escalate to the seniors, escalate to the consultant. Okay, so you say, I will discuss this, for example, with my consultant or with my senior. This will be considered as a patient safety. Also, take care, not everything you will need to escalate, because you are certified and you should able to do most of the things. Okay, so also the person who can't take a decision can be, say, fail in the patient safety. So yeah, you have to escalate when it is necessary to do that, but not everything. You should also have the ability to take a decision in your duty. Confidentiality can be considered as patient safety, right? So when you're respecting the patient confidentiality, and all of you know that there is a person in the hospital called the guardian, called the good guardian, right? Who respecting the patient confidentiality, or keep the patient information safe, all right? And no one should know anything about the patient information unless the patient know. When you're assuring the patient about her confidentiality, this is considered as a patient safety. For example, if the one of the patient come asking for emergency contraception, or for example, she is coming asking for abortion or termination, and she is already 16 or 17, and she doesn't want her GP or her parent to know. When you're respecting that and show that you show the patient that you are respecting her confidentiality, this be also considered as a patient safety. So please be careful of this point. How to obtain informed consent, how to assess the mental capacity of the patient. For example, the 16 years old young lady who come asking for abortion, how to assess the mental capacity. The patient with a very old, frail woman, how to assess the mental capacity of this woman, how to assess that she can do a consent. How did she understand the information? Did she can she weigh the risks against the benefit? Can she communicate her decision? All of this, all of this will assess the mental capacity of the patient as the Mental Capacity Act in 2005, right? So how to take informed consent from the patient can be also considered as a patient safety. When there is a complication of the patient and you go to inform the patient about this complication and to apologize for her, and this will be also considered as a patient safety, which we call this as the duty of condor. And duty of condor not only to apologize to the patient, no, you have to explain for the patient what happened exactly and why this happened, and what will be the prognosis of this complication. And you explain this for the patient and her family. This will be also considered as a patient safety, okay, which was called duty of conduct. Respecting the patient beliefs and the culture issue. For example, and the most famous one is Jehovah's Witness patient, the patient who refuse a blood transfusion, and the blood product also can be considered as a patient safety. But you have to make sure that there is advanced directive already, and this patient side this advanced directive, this can be considered as also a patient safety. So sometimes the patient refuse everything, so you have to assess that which blood product exactly she refused. Some may refuse the RBCs and they may accept the plasma. All right. So which blood product, and you have to explain for her what will be the impact of refusing this blood product. Not only take a consent, but you have also to explain for her what will be the impact of that. So yeah, sometimes a blood transfusion will be very necessary and life-saving, and if you refuse that, this may be affect and it may threat her life. The patient should understand that, and when you mention that to the patient and document that in your notes, this will be considered as also as patient safety. With a patient who coming from the country who do female genital mutilation, or already she has a female genital mutilation, and she is pregnant in pregnant with a girl. So when you mention that, and you mention that female genital mutilation is illegal in UK, and this also considered as patient safety. WHO checklist, all of the operation, you have to do the WHO checklist. right? So this can be assisted, for example, in the gynecological preoperative list, okay, which is a very famous case, okay, mostly common in most of the exams. Okay, when you mention I will do WHO checklist, which including the sign in, time out, and sign out, this will be considered as a patient safety. There was one of the examiner asked one of the colleague what will be included in the sign in, time out, and sign out, and this is the paper already for the WHO checklist. How to prioritize your case in your duty, which one you will go first and which one will be the most important. For example, the labor ward prioritization, which is also very common scenario, which one you will go first, whether you will go for the patient with massive bleeding or antepartum hemorrhage, or you will go for the patient with suspicious CTG, right? So sure, I will go for the patient with bleeding, all right? So how to prioritize the case can be considered also as a patient safety. If you are able to prioritize the case, this will affect the patient safety. So, especially in the very, very busy hospital, okay, when there will be multiple or very large number of the patient is waiting, which one you will go first? This will be considered also as the patient safety. In the part 3 exam, this will be shown clearly in the labor ward prioritization. The patient with collapse, I will go to the patient with collapse first. Patient with bleeding, I will go to the patient with bleeding first. This will be considered as a patient safety. When you're respecting the patient dignity, for example, if you examine the patient and asking her consent and make sure that you have a chaperone, is also considered as a patient safety. No one can examine anyone without a chaperone, right? No one, whatever male or female, can be examined anyone without chaperone at all right? The consent is something mandatory. You have to take a consent from the patient for anything you do, okay? And there should be a chaperone there. This will be considered as a patient safety. When you're checking the allergy, taking the history and checking the allergy of the patient, whether the patient has allergy for anything, this be also considered as a patient safety. Sometimes in the gynecological preoperative list, doing the pregnancy test in the woman in childbearing age, also considered as patient safety. Any question in the patient safety? Right.
Hello, sir, there's a question consent taking, and you said about there should be some laws like Caldecott principles. Can you little bit explain it in a clear way? A consent portion.
In the consent?
Yes, yes, consent. How to obtain the informed consent and principles and laws. Can you briefly tell us in an easy way that would be able to understand in a short time?
Yeah, I mean in the Caldecott principle and the respecting the patient confidentiality. For example, sometimes the patient will come um, and she wants certain procedure or certain treatment, and she doesn't want anyone to know about this procedure. For example, 16 years old lady who come asking for abortion, and her parent doesn't know about this pregnancy at all. When you assure the patient that I am here today to address your concern and respecting your wishes, and I want you to know that there will be no one know about this procedure at all except your wishes, except you agree for that. This will be considered also as a patient safety. So assure the patient that your discussion today in this room, no one will know about it at all. There will be no information go outside this room unless you want or unless you wish. What else? Patient who Any patient who come to ask for anything, for example, patient with medical disease, cancer, for example, she has a cancer and she doesn't want her family to know about this. Okay, this is we can respect the patient. We can respect the patient wishes, and no one should know anything about this unless the patient want. This is confidentiality of the patient. Confidentiality means that The patient clinical information or the patient data shouldn't be shared with anyone at all unless you want. So no one can call you on the phone number, onto the phone, for example, and asking for the information of his daughter, for example. No, I cannot give the information for this one who's calling. I didn't take permission from this girl to to let him know about that. All right. So, for example, is the sister coming asking for the information about her sister, about one of our patient. We cannot tell her this information at all unless the patient already come and she agree to let her know about that. This will be considered a patient.
Okay, sir. Sir, on which circumstances we are like supposed to breach the confidentiality? There are certain tasks when we have to disclose the thing that we have to breach that. Can you tell
Yeah,
an
we
example of
can
it?
reach that if it is, yeah, if it is affecting the law. If, for example, if there is a criminal issue, if there is some issue affecting the law, so after they this if if we do that, if we have that, there will be one person called the Caldecott guardian in the trust. The Caldecott guardian will assess this scenario, will assess this, for example, this case, and you check whether we can share the information with the third party, for example, with the police or with any other people. And no, this is not our rule at all. This is not our rule. So if the Caldecott guardian assess the scenario and say that yes, we can share the information after reading the paper, after assessing all the circumstances, we can do that. Right. So this is if affecting the law, for example, if it breaking the law in case of the criminal or something like that.
Okay, thank you, sir.
Thank you very much. Let's go to communication with the patient and the family. So communication with the patient, very important in this task. As part three already, it is most of it communication with the patient. And if you couldn't or fail communication with the patient, sure you will fail in part three exam. So in communication with the patient, how you will be assisted for the communication with the patient and the family? It will be assisted from the very early moment when you enter the cubicle or when you enter the room and try to make a report with the patient. Try to make some link between you and between the patient. Normally, I usually asked all my colleague or all my candidate to go neutral in that. When you go to the exam or when you go to the cubic, do go neutral and do gentle smile in your face, unless the scenario is breaking bad news or you will mention something bad to the patient like cancer or something like that. Otherwise, go neutral and do gentle smile in your face and introduce yourself and confirm the identity of the patient. Hello, I am Dr. Ali, one of the senior doctor in the clinic today. May I confirm your name and age, please? Yeah, with a gentle smile in your face. So this is to make a rapport with the patient, right? Then second thing, to try to break the ice. So when you're shaking the patient concern, I understand that you are here today to know about the result, for example, or understand that you are here today because you have some vaginal bleeding. Am I right? You will say yes. Do you have any other concern or expectation from our meeting today? Now you will ask the patient, you ask the patient to talk, or you will share the patient with the discussion. You will breaking the ice between you and your patient. Very important, your body language. When the patient talk, you should be active listening to the patient. As I mentioned, it is a day of acting. So try to be a good actor in that day. So how you show if anyone that you are active listening to him or her, when you have a good eye to eye contact, not looking here and there, up and down. No, make eye to eye contact. Do head nodding that you show to her or to him that you are active listening to him, and it try to do some encouraging voices, encouraging sound like hmm, hmm. This is very important body language. So communication not only with talking, body language also is very important in this in the communication. Show sympathy when you need to do that. Show sympathy to the patient. For example, when the patient cry or the patient will be angry, try to show sympathy to the patient. Your facial expression is very important. You can show sympathy as well by your facial expression, not only by talking to her or saying, I'm so sorry to feel that, I'm so sorry for your loss. No, also the facial expression will be very important. When the patient cry, to try to bring for her some tissue, there may be some of in front of you, bring some tissue and offering to the patient. Don't talk at all while the patient is crying, right? Don't interrupt the patient when the patient is talking. This will be very important in the communication with the patient. Try to focus on this, please. Try to focus on that, right? Don't talk while the patient is talking. Let her talk. Don't interrupt the patient at all. Give opportunity to the patient to give her a chance to talk. All right. Try to be not judgmental, mean that give the patient the option and ask her about her wishes. For example, if we are managing a patient with ectopic pregnancy, give her the option, like we have the wait and see, we have the medication, we have a surgery. What do you want to do? Do you have any preferred option? Do you have any preference? She will say yes. For example, I wanted to have the medicine. I don't want any surgery at all. Or she may say, I want the surgery. I wanted to finish this quickly, like that. Okay. So don't be judgmental. Don't force the patient to do something. Give her the option and let her try to do. Give them information in a small amount and check understanding. Very, very important. Not to only to keep talking. Okay, and the patient don't understand anything. The patient is not following you because you give her a lot of information. No, give the information a small amount or a small chunk, then check understanding. Am I clear? Is it clear so far? Are you following me? And try to change the question. This will increase your marks in the communication with the patient. Okay. If you draw, it will deliver the information very quickly and easy to the patient. Usually, I encourage all the candidates to draw. Draw any simple things, any simple. So, for example, if you are explaining an ectopic pregnancy to the patient and they started to draw for her, draw the womb, right, and draw the tubes, this will be very, very easy to the patient to understand. And this will increase also communication skills and communication marks. Respecting the patient autonomy. When the patient asking for something and you're respecting her autonomy, here, Mary, I'm here today to try to answer all your question and I will address all your concern, and the end the decision is yours. So now we are showing the patient who are respecting the autonomy of the patient. Okay, so respecting the autonomy, respecting her wishes will be very important in the communication with the patient. For example, if the patient have a very huge fibroid and she wanted to deliver at home, yeah, we explain for her everything, and we explain for her the risks and what are the alternative, and in the end, the decision is for the patient. The patient is pregnant in 4.5 kg baby, and she is diabetic, and it came before in the exam. All of these scenarios, it came before the exam, and she wanted to deliver at home. It's okay. It's her wishes. She wanted to have a normal birth, vaginal birth, not cesarean section. It is her wishes. We have to respect for her the risks and the alternative. At the end, the decision is for the patient. Okay, please respecting the patient wishes. Negotiate with the patient, as I mentioned, give her the option and try to explain for her the risks of the others, and at the end put a agreed plan between you and between the patient. Arrange You can arrange another discussion with the consultant. She can bring her partner again and they come back and they have another friendly discussion. All right, and put an agreed plans. Try to negotiate with the patient, not only to document or take a consent. For example, with the patient you have witness, no, try to negotiate, ask about the blood product which you refuse, and ask about the other alternative like the cell salvage, or give her the risks, what it will be the impact if she refused to have this blood transfusion. At the end, reach to agreed mutual plan. Avoid jargon, very, very important. Not mention medical terms like hysterectomy, uterus, laparoscope. All of these are considered as a jargon or medical terms, and try to use lay language instead of it. All right. And how we can know this lay language, as I mentioned, from the patient information leaflet. Okay, communication with the patient, communication with colleague. Communication with colleague, when you ask, as mentioned before, when you ask for a senior help, when you discuss this with your consultant, when you refer the patient to the baby doctor, the patient, for example, with a preterm labor, when she came, when you refer her as well, or ask the neonatal doctor to come to speak to her, this will be considered as a communication with your colleague. When you discuss, when you involve the hematologist, when you involve the blood bank, will be considered as communication with colleague. When the patient need multidisciplinary team, for example, in case of the cancer or case of very complex case, when it need a multidisciplinary team, will be considered also as a communication with colleague. SPAR tool analysis, how to discuss or how to hand over the case to the other colleagues by the SPAR tool analysis, also will considered as communication with a colleague. In one of the structured discussion tasks, the examiner asked the candidate how you will tell your consultant about this task, about this case. So he wanted from him to talk in the SPAR tool analysis. SPAR tool means that situation, background, assessment, and recommendation. For example, in the case of preterm labor who come to you on your duty, and she has some tightening, and you did some investigation for her, like the part to show or the amnisure was negative, and you examine her, the cervix was closed, and CTG was normal. Okay, so how you communicate with your colleague or with your consultant about this case? When you said situation, mean that I have a case of suspected or threatened preterm labor. Background, she is, for example, para one, has a normal vaginal birth before, she is hypertensive on that and that, she is diabetic on that and that, like that. This is a background. Then assessment, by abdominal examination, she has irregular tightening. The CTG was normal, and I examined her, the cervix is closed, and the amnisure and bartosure is negative. For example, this is your assessment. Recommendation, I want to admit this patient, for example, and this for giving her steroid, giving her that, giving her that. This is your recommendation or your plan. This is the SPAR tool analysis, how to communicate with your colleague about the SPAR tool. SPAR tool, situation, background, assessment, and recommendation. Applied knowledge, all of you know that how to what I mean. Applied knowledge, this will come from the green top guideline, the NICE guideline, and scientific impact paper, the TOGS. All of this will come from, will increase your applied knowledge. Your applied knowledge will be shown in the exam when you can justify the investigation and the intervention. For example, when you have some case and you said, I will do CT or MRI for this case. Why? I have to say why I'm doing that. Why I'm doing that. You said I will do full blood count for this patient. You have to say why I'm doing that. You said I wanted to do antiphospholipid antibodies for this patient. You said why you are doing that. So that's to justify yourself. I want to ask ask this patient about that. You have to justify why, not only to mention you will do that act. No, Why you are doing that? When you can interpret the finding, you interpret the finding. For example, if you have a scan which show that empty uterus and there is a mass outside, and the beta ECG is, for example, like 1,000 or something like. It is a pregnancy of unknown location. All of you know that. Okay, when you said I wanted to repeat that blood test again after 48 hours, I wanted to do ultrasound scan for the patient later on. This patient will have a possibility of that and that and that. All of this is applied knowledge when you can interpret the investigation, right? So interpreting the investigation, justifying the questions and the intervention, discussing the option of the patient. For example, again, the ectopic, when you say that we have a three option like that and that and that, this also applied knowledge, okay? So all of this will become from the your knowledge from the guideline, either the nice or green top or the top. Then the most tricky one, which is the information gathering, how to take information and relevant information. Usually we take a irrelevant information, okay, which will help you in the task to reach to definitive diagnosis or reach to the agreed mutual plan. So this is information gathering, how to take this information from the patient. And usually information gathering will be tricky because most of us will waste the time in taking the history, 5 or 6 minutes, and you will find only 4 minutes to discuss with the patient, the management, and to take a decision. And all right, so try to make the information gathering relevant and try to do it within 2 to 3 minutes maximum, right? And this to leave the other 7 minutes uh, for the scenario. Try to do template for yourself. Do template for yourself, all right, and keep repeating this template again and again and again. So for example, usually start by the history of present illness, all right. History present illness, when the patient come complaining of pain and bleeding, for example, I will start by that. Could you tell me more about that? Could you tell me more about that? And ask open question, right? Usually ask open question. The examiner likes to give the patient opportunity to talk. Ask open question will save your time because the patient will start to talk, and this give opportunity to the patient to talk and will save your time. If the patient didn't mention one of 2 points, you may ask a closed question. Can you tell me about the amount that is associated with pain, bleeding, vomiting, like that? So usually start by asking open question, then go by the closed question. And I want to make sure if there is anyone waiting. Right. Okay, so this is we're talking about the information gathering. Try to make a template for yourself. Okay, and this template usually will start by the history present illness, go to the obstetric, then gynecological history, then go to the medical history, surgical history, and when you try repeating this one and again and again and again, okay, this will fix the information or will make it easy for you when you are going to the exam. Don't ask and repeat the question again and again, okay, because this will waste your time and also will show the examiner that you are not concentrating with the patient at all, okay? Okay, so in the each task we have a 12 minute, 2 minute 2 minute for your to read the task in outside, and 10 minute to interact with the role player or with the examiner. In the 2 minute outside, there will be a task written in some paper outside the room. Okay, so you read this task carefully as you can, and try to write the important things. So where are you now? Where are you in the gynecology clinic? Are you the antenatal clinic? Are you in the urogynec clinic? Okay, try to, if there is the name of the patient, try to write the name of the patient if you can, if you able to do that. Try to write what is expected from you today. Are you expected, is it expected from you today to discuss the management plan? to explain for the patient the result of the investigation. So what is expected from you? So write for yourself what is the important point you want to discuss. Okay, so write, for example, I wanted to speak to discuss about this one, about to speak about the medical option, about and I want to discuss about the surgical option. So what you want to do, write in the paper. And as I mentioned before, and again and again, try to make one paper for one patient. So don't mix the patient in a single paper because it may confuse you in the exam. So one paper, you will have a note of papers. They will give it for you, and they will give you one pencil as well. So try to make one paper for every patient. Okay, and this not to avoid any confusion which will may happen. In the 10 minutes when you go inside the cubic, try, as I mentioned, try to be calm and confident in yourself, gentle smile. Okay, show the examiner that you are safe doctor. Be yourself like as in your normal life or in the daily practice. Um, Make eye-to-eye contact, as I mentioned before, to the examiner or to the role player. When you are speaking to the patient, to look to her, not to look here and there, up and down. No, avoid using the jargon and using the medical, and try to be active listening to the patient. Don't panic even if you don't perform a good in one task. Still, you can pass in this exam, right? So because all of the markers of the applied knowledge are will be collected together in on all of the scenarios, and all of the information gathering will be collected together, all of the communication will be collected together. So if you, for example, forget applied knowledge or you didn't do well in one task for the applied knowledge or the communication, don't be panic. You still can pass in this exam. Still have 13 tasks or 12 tasks if you didn't do well in two, and you still can pass in this exam. In this exam. Right. So let me take today some of the tasks on the early pregnancy. All right. So let me see who can share this task with us today. All right. So who want to share the first task with me today?
Sir, you mean to present a task?
Yeah, not present to discuss a task or share a task with me. So he will do the role of the candidate, and I will do the role of the examiner. As
Yes,
in
sir.
like
I can be. I can be if you allow.
Dr. Orouge.
Yes. But sir, your screen is not full visible.
Is it reasonable?
Yeah. Yeah, it's fine now. I take my 2 minutes?
Yes.
Okay. Is there any another page that is I have to see?
No, only this one.
Okay, hello, I am Aruj and I am ready for the discussion.
Okay, Dr. Rouge. Now you have this task, or you have this patient in the A&E, and she came with severe vomiting, and she has some vaginal bleeding. And your A&E doctor has done some investigation for her, which is shown already. So could you tell me what are the other clinical information you want to know about this patient?
So this the patient which I can see is like pregnancy, having a vomiting and her vaginal bleeding, and she is 31 years old, and she came in the emergency department with vomiting and bleeding, and she is her LMP is 2.5 months back, and with a positive pregnancy test. What I can see, there is in her reports, it's showing hyponatremia, hypochloremia, and I can see urea levels are raised and mildly elevated liver enzymes, and her blood group is negative. So I would like to need an additional information in the form of information gathering by taking a brief history and by doing investigations, relevant investigations, and by running some important investigations. And my recommendations will be depending on on the my assessment, and I'll be involving the multidisciplinary team approach. So where in the form of information gathering, I would be asking, like, she's in the emergency, so I would be offering her the emergency treatment, like offering her the anti-sickness drug. And if she has vitals that are according to shock, so I will be giving her the fluids. And if she has excessive bleeding, then I will be taking her monitors and will be doing some measures to avoid those things. And then once she's like fine to give the information, then I'll ask about her presenting complaints like her no vomiting, how long she's having, and is she able to eat or drink anything? Is there any is there any associated factor with the vomiting? And
Hello? Hello?
yes,
Are you with me?
yes, yes, I can hear you.
Yeah. Carry
Yeah.
on.
Yes, sir. About the bleeding, I will ask, and I will write to ask her gynae history and confirm her last menstrual period. Will ask about any treatment she has taken so far, and will check her labs if it is done, and any medical condition she's having, like is she having any problem like diabetes, hypertension, or any gastritis, any sign and symptoms of urinary tract infection she's having. I will rule out, and I will be ruling out any surgery as she's A negative. So I'll be checking her and previous obstetric history. I will inquire any specific family history, and then I would be like doing the examination in the form of general physical examination, like checking her pulse, blood pressure, respiratory rate, temperature, her dehydration level, her jaundice status, and I will ask about the personal history of like clot formation, if any, or significant family history of clot formation. And after examination, I will run some investigations. Like the investigations are already there, I would like to repeat them, and I would like to see the urine urine test, dipstick, to see the presence of protein, to see the dehydration, nitrates in that, and ketones present or not. I would like to check her sugar levels to rule out any diabetic ketoacidosis, and I will be checking. I would be checking her renal function test. To no, it is already done. Renal function test is done, and then in the form of like ultrasound, I would be inquiring about the status of the pregnancy, about the gestational age, and about the viability of the baby, like why it is twin, or she's having motor pregnancy, or like anything, I will rule out.
All right. That's good. So, second question, let me put. So this is the information of the patient here, right? You can have a quick read, then and
Primary
tell
abdominal
me what
spontaneous, no previous scan, constantly vomiting, ill, not pale, dehydrated, mild tender, 16 weeks. Okay, and 6% weight loss, hyperemesis gravidarum. Patient is having a pregnancy with hyperemesis gravidarum that is secondary to the molar pregnancy, and
right.
the ultrasound is showing molar pregnancy.
Right. So could you tell me what will be the treatment of this patient?
So I would be advising her, I will ask her for the support, and I will ask her to have someone to sit with her, as I have a lot of information to discuss with her, and I will explain it by showing a diagram. Like I will make a womb and explain the disease, that this is a abnormal type of pregnancy,
Mhm.
that is like not common, but it happens, and patient has to be admitted. And I will involve the team of doctor, that will involve my senior consultant, the senior consultant, and the anesthetist, and senior midwife, and GTD centers that will be involved. And I will be offering her the admission, and will explain her the treatment options. Before that, I will run some investigations, more investigations. Like as she is Rh negative, I will group save, and will group and save and will ask rule out any G who was witness if she is having. And then I will check for the chest X-ray, thyroid function test, and the beta HCG levels that I have to estimate it. And the options I will discuss with her that the surgical evacuation is required, and the procedure would be like taken after her consent, and will explain all the pros and cons, all the risks and if side effects that can lead to this, and I will explain her the procedure is important. And the procedure will be done by the senior consultant under the ultrasound guided care, and the products that will be removed from it that will be sent for the histopathology reports and my MDT. The histopathologist will also be involved, and we will be called in case of heavy bleeding. The senior consultant will be available, and hematologist should be involved in if we need a blood transfusion. So it may be there, and as she is A negative, but however the complete molar pregnancy is on the ultrasound and there is no definitive diagnosis. So it would be better to give her the NTD if the husband is Rh positive or it is clearly until or otherwise it is like husband is negative. Otherwise, we will give her the NTD and we will make sure the histopathology form is like there and it should be signed before it and it should be sent and we will be calling her for the follow-up after 2 weeks and we will register herself into the GTD center for the follow-up and the patient recovery. And when at the time of discharge, we will be telling her if she feels like heavy bleeding or any pain or like any nausea, vomiting or something like that, she should immediately report and give her the contact number and will also give her the idea of contraception that for the rest of the follow-up period, she has to use a good contraception, but I will tell to avoid the copper IUCD because there are chances of increased perforation during that period up to the time of follow-up. Other than that, all contraception methods would be like suitable for her. And I will make sure to tell about follow-up after the histopathology report.
Right.
And during that time, sorry, I forgot, I will be resuscitating the patient first, like she is in an emergency. I will be admitting her, resuscitating her. After that, I would be doing all these things.
Right. Great. Could you tell me what is the follow-up of the molar pregnancy? How will be the follow-up?
After the histopathology reports, if the histopathology report confirms that it is a complete mole, then we would be calling her to a GTD center, and they will be giving her the important kits like urine collecting kits or some beta HCG kits. So then she can follow up with her GP. So a GP would be calling her weekly and would be checking her beta HCG level at the weekly level, and if it is complete, we will be doing the weekly beta HCG for up to 56 days. And within these days, if the beta HCG remains normal, we will follow up till the 6 months at the day of evacuation, from the day of evacuation. And if the beta HCG level is not found normal within the 56 weeks, then we
I
will
am
be
finished. Thank
yes,
you.
we will be doing follow-up.
Thank you very much. Thank you very much, doctor. Well done. Well done. Excellent. Did you go on the exam before, or this is your first time?
No, sir, I'm planning for May.
Okay. Okay, great. Great. So yeah, you did the task in very good way. And the good thing that when you assess the patient safety in the start, when the examiner asks you about what you will do, the good thing is that when you start, before you talking to the patient, before you started to talk to the patient and to take the information for her, you assess the patient safety, that she is able to talk, the bleeding is just minimal, and if there is severe bleeding, you have to resuscitate the patient, offer the patient antiemetic before you started to talk the patient, like that. So this is will be considered as a patient safety. This is very important, and you show that very nicely. You managed to interpret the investigation and to give the consultant or the examiner a brief about the story in front of you when you are talking or when you are reading the scenario. You managed to do that. So this was very good. And you started to take the information in a systematic way. You started by the history of present illness. This was very good from you as well. You started by the complaint of the patient, then go to through the story or through the history, obstetric, gynae, medical, and everything. If you in the medical, you try to justify the medical, for example, you ask about the diabetes or try to mention which is specifically in the medical history you want to ask. Like I will ask about history of diabetes because this patient may have a diabetic ketoacidosis, or I will ask about the thyroid because this patient may have uncontrolled thyroid problem. It will be more and more informative. And also about other medical illness like epilepsy or psychotic illness or HIV, which the medication or not taking the medication of this illness will complicate the condition, as the new green top guideline mentioned there. So some of the medication which not taking, sorry, some of the disease which not taking the medication may affect or may complicate the problem, like the epilepsy or the psychotic disease. So I also wanted to know about if the patient has any of these and any, if the patient taking medication for all of this problem or no. This patient has a possibility of ectopic pregnancy because she has a bleeding. So whether she had a history of ectopic before, whether she has a history of surgery before, if she has any history of bypass before because she has this vomiting, and this vomiting may be because of any gastric sleeves before. Okay, so in the surgical history also, if you could mention which of the surgical history, which of the surgery you want to ask, try to specify one or two will be very, very amazing from you. Okay, whether she is using any drugs, this drugs this vomiting may be induced by some drugs. Okay, this will be also will be very informative. Smoking, okay, because this patient at risk of having ectopic if she's smoking, and how many cigarette, domestic, and assure that the patient is safe at home, she has a support and she is safe at home. This patient may have a domestic violence, will be also very amazing. So try only to add this very small information to your information gathering. Put differential in your mind in the start. So for example, when your examiner asks you what you want to do about this patient, if you start by talking that this patient may be what this or that, put a differential in your mind, it will be very also amazing from you to tell the examiner that you are thinking broadly, you are thinking widely about many of the scenarios may happen because this bleeding in early pregnancy may be miscarriage, maybe molar, maybe ectopic. So I put a differential in my mind that this patient may have that or that or that, and I started to ask the questions to reach to the definitive diagnosis. Examination wise, excellent. You mentioned everything in the examination. I think you forget to mention about the weight, to ask about the weight.
Sir, I forgot fundal height as well, height to weight ratio and fundal height
All right,
to
good.
measure.
Good, good, good. Signs of dehydration as well. Okay, to assess how severe is this vomiting. If you could look for the signs of dehydration and signs of the malnutrition, as also the green top guideline mentioned there. Investigation wise, you mentioned it very nicely. In your woman with the vomiting, you will dip her urine to check whether she has any infection, and if there is infection, you will send for MSU and look for the ketonuria. Now, the ketonuria not a degree of severity at all in the green top guideline. We don't depend on the ketonuria as a degree of severity like before. Ultrasound, you mentioned that, okay, and this to exclude molar pregnancy, multiple pregnancy, viability, to look for the viability and the gestational age. The examiner gave you a piece of paper which shows the history and the examination and the result of the investigation, and you managed to interpret that. Excellent, excellent, well done. So the next question was about the treatment. Very good that you say this patient need admission. Very good. This is a safety point. So no patient with this bleeding and this severity of the vomiting, I will discharge her. So admission will be also considered as a patient safety in this task. Discussion with the seniors, the multidisciplinary team, this patient need to be discussed. Also, you mentioned that rehydration fluid, the most important thing in the vomiting or the hyperemesis is the rehydration. It is the best treatment or the first important thing you have to do for this patient is to rehydrate her again. And then all of you know that that is a normal saline with addition of the potassium chloride in each bag guided by the by the daily serum electrolyte. It is the best regime for the rehydration. Anti-sickness medication. You forget to mention about the thiamine and low molecular weight heparin. Any
Yes, she's at high risk of DVT
yeah,
now. I
admission.
wrote in my 2 minutes, but I forgot.
Yeah, it's happened. No problem at all. So this is the importance or the benefit of repeating, or you have a study partner which who will tell you that you forget that. So yeah, any patient you admit in the hospital, especially the patient with the hyperemesis, you will need to give her stocking in her legs and the low molecular weight heparin. So put it in your mind. Antenatal, any patient pregnant. Admission, stocking, low molecular weight heparin. If this patient needs thiamine, either it is oral thiamine, 100 milligram TDS, or paparonex IM injection, and this to avoid the wrinkles encephalopathy. So the new guideline recommend to give all the patient who is admitted because of the severe of vomiting thiamine, not only the patient who will have the dextrose, not only that patient. No, all the patient now take thiamine. Antacid, either the H2 receptor blocker or proton pump. It can be either, but you will give her antacid and will daily serum electrolyte and monitor the input and the output. You mentioned that you will need to do baseline beta ECG for this patient. Very amazing. When you mention that this patient need a treatment and that and that and that, you have to explain the result of the patient. You may also tell the examiner that I will explain for her the result in breaking bad news, because this will be the first time to know that she had a molar pregnancy. So I have to tell the patient this information in breaking bad news way. Okay. And we will speak about the breaking bad news later on when we take a patient in the simulated patient task, how you will do breaking bad news, how you will give the patient some posting, how you give her the first warning, how you will set the scene and check the patient can cope with this information that we will give her today. Okay. So then molar pregnancy need a suction evacuation guided by the ultrasound. You justify for you the anti-D, amazing. However, this patient is RHD negative and she has a complete molar on the ultrasound scan, but this is not definitive, the definitive only by the histopathology. So you mentioned that you will give this patient anti-D, and this was amazing from you. She needed a registration in Trophoblastic Center, which is present in London or Dundee or Sheffield. Okay, you just need to fill the form and send it online to this one of the centers, which is the nearest to you, and this center will contact the patient and start to send it for her the kits and that and that and that. The follow-up of the molar pregnancy, as you mentioned, if she has a complete molar pregnancy and the beta HCG return back within 56 days, she will need follow-up for 6 months only from the date of the suction. If it didn't return it for within 56 days, so it will be 6 months from the date of the normalization. In the partial molar pregnancy, according to the new green top guideline, that it need only two beta HCG normal, two sample only for 4 weeks apart. 4 weeks apart. This patient will need a beta HCG later on or no. According also to the new green top guideline, there is no need to do beta HCG after any new pregnant event unless the patient receive chemotherapy. Only if the patient receive chemotherapy, we don't do pregnancy hormone in any after any future pregnancy unless the patient receive chemotherapy. If the patient has GTN and she take a chemotherapy, now we can do the beta SG again after any future pregnancy. But if she didn't receive, no need to do this beta or pregnancy test or pregnancy hormone. She need an early ultrasound scan in the early pregnancy. She can refer herself to the early pregnancy assessment unit. No need to call her GP. No need to come to the ED. She can refer her immediately in any future pregnancy to the early pregnancy assessment unit to do an early scan. Patient information leaflet, don't forget that as well. This patient may give her, even if it in the simulated patient, sorry, in the structured discussion task, you may ask, I will give this patient also patient information leaflet to read till everything be ready for her or during her admission. Thank you very much.
Thank you so much, sir.
This one, we need to take another one. Yeah, this is a new classes or the classes of the anti-emetic, which is present in the new guideline. Okay, which include another new drugs called the diloxamine and the pyridoxine, which called the Zenuvia in the pharmacy on the trade name Zenuvia. This contain diloxamine and pyridoxine. This one is newly added in the new guideline. All the remaining the same. Who want to share the next one? We'll take simple one.